ये हिरेन चल गए ओ भाई हिरेन को बोलो अरे पूरा भाई सेशन कर yeah. So yeah, I think we've got the okay.
So this is
I tried that. It didn't work. Oh, sorry. Fine. So very common as we see, it's 30 to 40% of all visits to the doctor. Worried parents, especially grandparents. And what you need to do very quickly is to take a quick practical age-based etiology to find out why this is happening. So let's divide this topic into two parts, fever in infants and toddlers and little bigger children. So now when neonates are concerned, who have just come back from the hospital, age less than 7 days, age more than 7 days, they are best, I think, managed by an expert. Family practitioners may not be comfortable with a 7-day infant. Sometimes the signs and symptoms of some major problem may be very subtle, so it's difficult. Early referral usually is the best option when a child is so small and has just come back from hospital. But the other important thing is you have to take history of how the delivery was, what was the birth weight, did the child start feeding on breast before he came home, and whether malish is being given already, things like that. So you need a high index of suspicion. Dangerous signs are poor feeding, lethargy. If a child can't suck, he's very sick. Irritability, sometimes convulsions. So yeah, so that is the big problem. Here again, good history from the antenatal ultrasound. What was the prenatal period like, birth history, whether the mother or somebody is sick, whether or not breastfed. Usually breastfed babies do well, almost never fall sick. If there is jaundice, which you can see, look at the umbilical stump, if that looks infected, whether there is non-stop vomiting, the child just cannot be consoled, and peripheral pulsations being not good. If you find that the fontanelle, which is always open at that time, whether it is depressed or bulging, either way it is a problem. So mostly it is better to see a pediatrician here or let them go to the hospital where they delivered, because somebody has to see this child. When you have a child who's already been at home 1 or 2 months, when they have very high fever or something, one of the main things to rule out is urinary tract infection. Now, urinary tract infection is very, very difficult to find at this age. The child doesn't tell you, but the child is very toxic usually. And the only way is to take a urine test. Now, the problem is again collecting urine. Even a general urine routine, there is a very nice neonatal bag available, which you can just attach to the baby's groin. At least that will tell you if there is significant urinary infection or not. Then cultures will have to be done as you go ahead. Again, once you know it is UTI, somebody else will have to treat. Others are viral infections and bronchiolitis, where a family history is very important. The warning signs, we even tell our nurses in the villages, if the heart rate is very high, if the respiratory rate is very high, the child is very tachypnic, very ill appearing, there is a lot of retraction in the suprasternal notch, intercostal, subcostal. If there is delayed capillary refill, if the umbilical stump is still there after so long, abdominal distension is a problem. Yeah, and then again, referral. The workup for a sepsis child, usually I don't know, but whether general practitioners would be comfortable, but any WBC which is more than 15,000 now, with a shift to the left, mean lots of band cells, should warn of severity. On the other hand, if the infant is appearing well, if he's 2 months and smiles, If you see him feeding on the breast, there has been a full-term birth, no adverse history, the weight gain has been okay. You can't find a depressed fontanelle, you can't find a very tender ear, you don't find any boils anywhere. Urine routine doesn't look so bad. That is not usually a problem. A CRP which is not high at this stage is a very important sign that it cannot be too serious. There you could wait for a day maybe and see how it goes. Plus a family history if somebody else has fever. So this is about the little babies, 7 days and less, 1 to 2 months. And now we go to bigger children, which is what you'll be seeing all the time. Now, if you take 100 babies or 10 babies, almost 9 are going to get better without any treatment also, right? Only problem areas are you have to deal with children who have a history of febrile seizures or convulsions, or with a family history of the same, of the siblings, brothers, sisters who had that. If the parents are on anti-epileptic drugs, these children have to be slightly more aggressive on the management of the fever to bring it down. And the drugs used to bring down fever should be in the right dose and appropriate. So paracetamol should be the first line. And the dose would be 10 to 15 milligram per kilogram per dose. Normally not more than 4 times a day, can be given in some cases every 4 hours. And if the fever does not come down, you can combine it with ibuprofen also, but not a combination, please. See, if you have 2 drugs given at 3-4 hourly intervals, one at a time alternately, the fever is controlled better. You can give them both 3 times a day, and the fever will come down without being drastically brought down. Mefenamic acid is very popular to bring down fever. I usually don't use it. I mean, combinations with paracetamol bring down fever very precipitously. Child goes cold, clammy sometimes, and the temperature goes to 92, 93 degrees from whatever 101, 102 that it was. So it's best not given. In the West, they use suppositories also in Gulf countries of diclofenac, Bovril. I don't think, it's overkill to use that for fever. It's good for when you know an inflammatory disorder, rheumatic disorder, rheumatoid disorder, where you need to give it or something for an acute pain. And please, 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 I think you should remember not to give combinations of 2 drugs. It's better to separate the 2 drugs and give them separately. Makes tremendous sense. It's like if you have 12 guards, it's better you can have 4 shifts of 3. If you have 3 guards, you'll have 3 shifts and they'll all be sleepy and you'll have a robbery. So this is where you have to be worried about. In children with history, now febrile seizures are very common. 4% of all children below 5 years. In Bombay, there must be at least 2 lakhs or 2.5 lakh kids who had at least one febrile seizure. So you take a history, family history, and you should look for whether it is a typical febrile seizure. Most febrile seizures last very little. The parents think it's very long. It's always generalized. You must make sure the cause of the fever is not some brain or CNS cause. It can't be meningitis. Then it's not a febrile seizure. Almost never exceeds 10 minutes, but I have never seen any going more than 1 or 2, 3 or 5 minutes. And always generalized. If you have only one-sided, then that needs to be investigated. Good recovery within an hour or so is absolutely as if the child had no problem. And then the age. So if you have a child who's at below 6 months, if you have a child who's had this, more than 6-7 years of age and never had one before, it's unlikely to be the first time febrile seizure. So you have to look at again the paracetamol, ibuprofen, alternately sponging. It is here in febrile seizures what all of us don't know, and which is really true, is that it's not the degree of fever. If you have a slow rise of fever from in 4 hours to 103, you may not get a seizure in a 3-year-old child. If you have a sudden rise, in 5, 10 minutes, 15 minutes, suddenly the fever has gone up, there is very likely to get a seizure. And you cannot predict this. It's always better for 1 or 2 days to give alternate drugs. Sponging should always be with tap water in Bombay. Because if you use ice water, which people will tell you, it causes a vasospasm, which is reflex, and then it will cause a sometimes rebound rise in fever. And preventive measure. Now, people also give drugs for frisium and clobazam. That actually drugs have no meaning because the level of the clobazam to come to a protective level will at least take 8 hours, 6 hours, 8 hours. By then, if there was a seizure going to happen, it will happen. So I don't think that it makes much sense. When there is fever, start giving frisium. That's not true. I think rather sponging with tap water, with the child's clothes off and 5-10 minutes, temperature will come down immediately. Paracetamol, ibuprofen, good drugs. So you have to be slightly aggressive on children for the fever treatment when there is a history of this. Just now, we're just going to go 1 or 2 specific causes. We've just started dengue season. We've had lots already. It's actually going to come much more later after the monsoon recedes. So it's very common. Almost never, contrary to what people think. Dengue, they get very scared. Children usually don't have such a bad deal most of the time. Of course, there will always be exceptions. And then the problems are, like I said, dengue, hemorrhagic fever, and dengue shock syndrome. I have dealt with so many dengue patients, and I have not yet, thank God, and I pray that it continues, ever had to give a platelet transfusion. Yeah. So again, this is a vector-borne disease. So because of the mosquitoes, which are daytime mosquito bites, there's an incubation of 4 to 10 days. Symptom, there may be a family history. You have chills, rash, high fever. One of the characteristics people say is a bad headache behind the eyes. Weakness, fatigue. Sometimes there are lymph nodes here, so which may think this is a throat infection. The throat, when you look inside, is okay. So this is one thing. When you do blood tests for fever, like otherwise, the 5 to 7 days, the fever sometimes, usually in 2-3 days, are high. Saddleback fever means there is 3-4 days of fever, then there is a calm period, and suddenly the fever comes up again. Now, these are little problematic, and these are more likely to have complicated dengue. So these should be referred. If you have very severe leukopenia and thrombocytopenia, actually are part of the disease. I'm just going to show you in my next slide. And don't get too overly worried, and I'll tell you when to get worried. So severe dengue is when there is 7 days of fever and plasma leakage. So there is a leaky plasma and the fluid extravasates out, which causes a drop in the blood pressure, drop in the peripheral circulation, feeling weak, fainting, these kind of things. Sometimes there is bleeding from sites of trauma like GI, vomiting, hematemesis. Sometimes this is not uncommon in severe dengue. Abdominal pain is because usually hepatomegaly. If vomiting because of everything together, platelets are low, and what are the danger signs? If the PCV or the hematocrit, which every now report of CBC gives you, if it is rising, if it is very high, that means there is dehydration because the fluid has leaked out. That is a little dicey situation and should be referred. If there is very high liver enzymes from the beginning, that is dangerous. If there is 1,000, 200, 1,200, these are again likely to have a problem. I mean, they will resolve mostly, but maybe not. Here is an illustrative example. Here is a child, say on 9th of October, hemoglobin 11.7. Look at the PCV. Look at the WBC. Look at the platelets. Platelets look fine. WBC is slightly low. This is a very characteristic. Also, I have not added here, but neutrophils sometimes are quite high as a proportion. 3 days from there, you suddenly find the hemoglobin has gone up. RBC count has gone up. The PCV has gone up, means there is a leakage. Now, WBC is 1400. and the platelets are 112. Again, I don't think you just have to wait it out. These are not dicey situations still. 16th, you find it's gone up higher. But then what is the good thing you see here? You find that the WBCs have started rising. So the WBCs rise faster than the platelets. So don't only look at the platelets. Once the WBC is rising, means the bone marrow has started recovering and the platelets are going to recover. Platelets have a very short life. Their demand is very high. I mean, you need billions. So it takes time to make up. But on 17th, I'm very happy. It's gone back to almost previous levels. And you have a normal WBC count almost. And the platelet is shown a rising trend. Beyond that, you don't need to do any more blood tests anymore. At the end of dengue, you get a very bad, sometimes red rash, which actually means it's probably the end of dengue. Yeah. So this is dengue. When you hospitalize a dengue patient, excessive vomiting, that will hospitalize any child who excessively vomits, doesn't take. Hemorrhagic phenomenon, a saddleback biphasic fever which has come back, reduced BP capillary refill, severe abdominal pain, breathing difficulty, which abnormal ultrasound. That breathing difficulty sometimes is because there is leakage in the pleural fluid, pleural cavity, and there may be difficulty breathing. An abnormal ultrasound, once you reach a hospital, a very drastic drop in platelets or a very rapid rise in the PCV, very high liver enzymes. And if the coagulation things, PT, PTT kind of things are not good, then that is then hospitalization. We are also getting lots of malaria, right? And even in the times of the COVID, I myself in Cuff Parade, Kolaba, have personally reported 400 cases of malaria to the municipality. This is a reportable disease. You have to give the name, the addresses of all the people who come positive. And luckily for us, there are very good tests now. So fever with chills, rigors, headache, everybody knows that. You have quite normal periods usually in between. If you look carefully, you will find the spleen almost always enlarged. And please, today now, at least today, most cases are Vivax. And the drug of choice is chloroquine. The drug of choice is chloroquine. The drug of choice is chloroquine. I am repeating 3 times because nothing works better than this. From the day that you start the first dose in the right quantity, 36 hours from then, almost 99% children will be fever-free. The use of other drugs like lumefantrine, artemether, some pyrite, sulfur drugs is completely wrong in Vivax. It's completely wrong and should be condemned. Also, if you have Vivax malaria, you must get a G6PD test done because we need to give this child Primaquine. There is an exoerythrocytic schizophrenia. The parasite can stay dormant in places like the liver for 2 months and then will cause a relapse, recrudescence of malaria. So therefore, Primaquine will cause immediate and radical cure of malaria. But the other thing also, even 1 dose of Primaquine kills all the transmittable parasites. So it reduces the transmission in the community. Malaria sometimes can have family history. I mean, there are 2-3 members of the family in a big family who have malaria. There are neighbors who have malaria because the mosquitoes are the same. For falciparum, this drug combination I've seen works very well. Don't use other drugs for Vivax malaria. Very important. Follow up Vivax malaria with a course of Primaquine. Extremely important. Please report your cases to the BMC so that the care of the community can be taken. Proper mosquito control and stuff like that. The other thing is enteric fever, which we used to call typhoid. Better name is enteric fever. Usually 3 to 16 years of age. Here, a word of caution. Some places in Bombay and its extended suburbs have such bad water and contaminations. Typhoid is fecal-oral. So there is human feces in the drinking water. That's the only way typhoid is transmitted. So even bath water, sometimes I've seen Salmonella typhi grow in a 4-month-old child. How is that possible? He's breastfed. But maybe he swallowed a little bit, but the inoculum is so high. Also, typhoid germs, the stomach is so good. You have to need a huge billion dose bacteria to cause typhoid. The fever pattern, people say all of it doesn't matter. It's a W shape, M shape, all these things. But high fever, it just comes and goes, very erratic. Doesn't get better. You have a splenohepatomegaly. You have an abdomen which you can play the drums on, like a tumid abdomen. Vidal test is completely useless. Please, my esteemed colleagues, do not ask for a Vidal. A Vidal test, which measures the antibody response to the germ, comes positive in a mild way in 10 to 14 days. And to prove it on Vidal, you should then repeat a test after 14 days to show doubling of titers. By then the child will be okay. One of the other clues on a CBC, which my teachers used to tell me, and I still think it's there, that if you find 0 eosinophils, sometimes that is an indicator, but that's not a diagnostic sign. Rapid tests measure the antigen. I myself am not very convinced, unless the quality is very good and all that. The most important thing when you suspect typhoid is that a blood culture in a Bactec aerobic bottle. Blood culture in a Bactec aerobic bottle, which is done everywhere, must be done. That Bactec bottle promotes the growth of the bacteria in the culture medium. In a day or two, if the lab is good, they'll send you, doctor, this is beeping. So it's growing salmonella growth. And you'll have a sensitivity. Today, the drug that we use is azithromycin because it is an intracellularly penetrating drug. And this drug, this parasite is intracellular. Sometimes people say that if you use azithromycin, the relapse rates are low. Cefixime is also a drug, just given for at least 10 days, the dose is slightly higher. The good old days, it used to be if you give, the standard chloromycetin, and if the 3 days the fever goes away, it is typhoid. But today, chloromycetin is available again. What our senior doctors will know, Paraxin. It's back, but it's slightly in that sense, once in a while you get a very idiosyncratic reaction to chloromycetin, sudden bone marrow problems. Again, combinations like this, please look at this picture. Paracetamol, mefenamic acid. Look at this picture. Cefixime and ofloxacin. Almost all enteric bacteria, the salmonella, are resistant to the oflox, ciflox, norflox, whatever, pflox kind of drugs. And the key is, if you look at the sensitivity of any positive blood culture that you see, if it is resistance to nalidixic acid is there, then these drugs cannot. The combination, the dose is so idiotic. It is only that because we have such a corrupt FDA and a licensing authority that these drugs are allowed by reputed companies. And nowhere in the world is this available. Please, please, please do not use this. Then the other new drug which is being promoted is meropenem, oral. Any child, according to me, who needs meropenem antibiotics should be in hospital. There is no scope for oral meropenems. And it has to be done in a very proper person. This is just going to finish the most effective antibiotic that we have today. And there has been no antibiotic developed after this for the last 10 years. There is no antibiotic coming in the pipeline. So please, 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 I don't know all the brands I tried to find, but they are all promoting the the medical reps, please do not do this. Tablets also are available at home, right? The other causes of fever are respiratory infection, upper respiratory infection. Again, I want to tell you, do not use cefixime for this. It's very popular with doctors and family practitioners. Cefixime has no action against strep, has no action against staph, has no action against Haemophilus, which are the main organisms which will cause a bacterial throat infections. First generation cephalosporins are great. If it's really severe, a combination of amoxicillin and clavulanic is great. Azithromycin in school-age children, because a lot of these infections are mycoplasmal. So please do not use cefixime. We are getting resistant bugs to cefixime now because of overuse. Everybody uses this. Cefixime, good drug for a urinary problem. Lower respiratory bronchitis, pneumonia pickup is very important. And if you keep giving ibugesic plus and mefenamic paracetamol combinations, you will actually hide the signs of a big pneumonia till it gets really bad. So don't use these drugs. And if there is tachypnea, those early warning signs, chest signs, let them be seen, let them be examined. And a chest X-ray makes sense. CBC findings will tell you when the counts, when you see. Swine flu, suddenly I read in the papers, it's back again. Just now, but in children, it doesn't do much. Please do not use aspirin. I don't think anybody uses anymore. Because aspirin, when you use in H1N1 kind of flus, can sometimes cause very severe adverse reaction. Things like Rey syndrome and oseltamivir is the drug. The idea of giving it is it should be given on day one to be effective. I don't know whether it really works, but it definitely slows down the transmission in the community. But again, I am not, unless there is an old man in the house and old people, this is okay. I don't think I am too worried about it. I usually give nothing but paracetamol. Viral infections are the most common. Measles, mumps, rubella now are less because of a lot of vaccinations, which is very good. Roseola infantum or exanthum subitum is one infection where you get very high fevers for 4 days, really scary fevers. And then 4th, 5th day, there is a rash and the fever disappears like magic. Of course, mothers will say this is khasra, measles, gover. That's not true. Chikungunya was back last year. There's a lot of pain in the joints. Again, there's no treatment. UTI must be ruled out. Kawasaki is another thing which is very characteristic sign that the fever just doesn't. Other rheumatic conditions, if the fever is prolonged, have to be investigated. So this is a good list. If you want to investigate, say, a 5-6-year-old child who has fever for 3 days, not getting better with what you're doing, a CBC will tell you lots, almost everything. If you don't want to do anything but only one test, I would do a CBC and a urine routine. That will tell me everything. A malarial antigen is very, very accurate. It takes away the technician's proficiency from the report. Even if the technician is not good, this report is very sensitive. It will also tell you whether it is Vivax or Falciparum. Dengue NS1, a urine routine, a chest X-ray, CRP, a liver enzyme, a blood culture backtech if the typhoid is suspected, a urine culture when there is urinary infection on the routine, and a sonography. I think beyond that, no other tests almost are needed. Find a cause of a fever in a child. Now, when you go to 10 days, 15 days, 20 days fever, then you have to do all those rheumatic fever tests, rheumatoid factor, and all those things. But that is, for specialists again. So this is where I think we should stop at investigating a fever. COVID-19, you can't ignore COVID now since we are in COVID times. And and cough, fever may or may not be present. There should be a high index of suspicion, family history. Nowadays, we have rapid tests at home. It's not at all difficult to do and check on this. So this is about this. I think that's about it. as far as I am concerned, we are now, if anybody has any questions or whatever, everybody can go on, and I might, let me see if there are already some things that I can see already.
Thank you so much, Dr. Paresh. That was a really good lecture. I think it covered everything we need to know about fever in children. So one of the question is, what about the hand, foot, mouth disease?
Okay. Oh, I'm so sorry. I forgot that. I should have shown you pictures. Oh, sorry. So this is just now rampant. Let me please reassure everyone here that is watching. No child ever needs hospitalization, ICU care for hand, foot, and mouth. It's self-limiting. It's usually seen in children below 4 years or 5 years. And usually you get it one, but there are many viruses which causes this. Sometimes Coxsackie, they say, nobody knows. And you have the rash is usually seen on the hands and foot, and very odd is in the palm and the sole also. The elbows, the knees, and the area behind below the buttocks, they are almost always there. If the child will open his or her mouth, you will find there are ulcers on the palate and near the tonsils, which are very painful. So you give symptomatic relief. You give paracetamol. If that doesn't work, you give ibuprofen, because then the pain goes away. The child starts eating, which is what the child mother wants. And some itching, sometimes it's too much, you can give cetirizine or something like that. Plus, you could go with soothing lotion like paraffin, calamine combinations, which are rampant in the market. Everybody knows. That's it. Nobody, 3 days, of course, the school will insist the child doesn't go. Yeah, you can limit the spread. But even if it is spread, so what, according to me. But that's about it. You don't usually get it in adult or elderly children. Right. You do get sometimes 7 or 8 year olds because they missed it in their childhood. But that's about it. Just now, I see at least 2, 3 every single day. But it's nothing to worry about. I got pictures. I wish I had brought them.
Yeah. So another question is from Dr. Vinita Shetty. What is the dose of chloroquine in children?
Okay, so simple. I'm telling you. These are mathematical doses. Please, please, please follow this. Dose 1 should be 10 milligram per kilogram of the base. All these syrups that you give, and I'm sorry, I'm saying the brands. One is Nivaquine P and one is Lariago, which are very easily available, extremely cheap. So 1 ml per kg as the first dose. 6 hours from dose 1, you give half of that dose. 24 hours from the first dose, give another same half of the first dose. And 48 hours from the first dose, you give the next dose, which is also half of the first dose. So if there is a 20 kilo child and you're giving Lariago syrup, you give 20 ml at say 10 a.m. today. At 4 p.m., you will give 5 ml. At 10 ml, 20 ml on day 1, first dose, 10 ml at 4 p.m. today, 10 ml at 10 a.m. tomorrow morning, which is, let's say, Thursday, and 10 ml on Friday morning. These 4 doses are more than enough for curing this malaria. Now, 36 hours from dose 1, 99 out of 100 children will be fever-free. Do not use other drugs. You must get a G6PD done and start Primaquine. You will limit the spread of the disease, and 10 to 14 days of Primaquine post will reduce the relapse rates. That's chloroquine. Mathematical. Absolutely mathematical.
Sure, sir. Thank you. So there's another question from Dr. Himali. How to diagnose Kawasaki and what is the treatment?
Okay. So Kawasaki means the fever is really prolonged and it just doesn't go. People have already given antibiotics, they've given everything, typhoid treatment, all these, nothing really works. The fever just keeps coming back. And then you will find there are some lymph nodes in the neck. It's called a mucocutaneous syndrome, used to be called first. So that is the other thing. Look at the tongue. There is a very bright strawberry-like tongue. Now, all these things are not always there. So you need a high index of suspicion. And then you have the rash which comes. Now, the rash usually many times comes in the end when it's getting better. And therefore, and it's like desquamating. The skin peels off, just like a new layer of skin comes out. But that is 10, 15, 20 days later. It is too late for us. Good to refer. A blood count usually will show very high platelets and a CRP which is really scary. 160, 500, 200, 80, 95 like that. But you don't see any focus. He's kind of, if this was a tonsillitis, the child would be very sick. These children are not that sick. And you'll find the conjunctiva. There's limbic sparing. The conjunctiva is bright red at one end. So once you see my Dr. Kupchandani, who is my guru in this, if you see one, you'll never miss another. Till you see one, you'll never know one. But once you know, the problem with Kawasaki is we need to treat it, because one of the problems with Kawasaki is it also affects the small coronary vessels. And therefore, once you diagnose coronary, a pediatric cardiologist has to do an echo of the child. You have to put the child here on aspirin. And intravenous gamma globulin is very important. Not only does it bring the fever and everything down, but it prevents early coronary artery disease when this child is 25, 35, 40, 30 years from today. And therefore, it's very important. They do a Z score. They are very technical echo parameters for this. You go to a good PD, he will know. You do it, you give the gamma globulin, you repeat it. You may have to do a follow-up echo later. But that is why Kawasaki is important to diagnose and treat. Sometimes in smaller children, you get an incomplete Kawasaki, where half and half signs are there. But it's better to do at least an echo to find out that the heart is okay. Yeah, that's Kawasaki.
So another question from Dr. Meena is, what is the safest antihistaminic in a child less than 6 months of age?
So less than 6 months, I don't know whether antihistaminics really work, but hydroxyzine, that is Atarax, works. Doesn't do any harm at least, causes little sleepiness, but it's quite safe.
Okay.
Little bigger child, you are the boss, Shruti, but cetirizine will be given, but I really don't know.
Yeah.
Other things don't know.
Sure, sir. Another question from Dr. Bhatt is how to diagnose chikungunya.
The chikungunya you can't diagnose because there's nothing, there's joint pain, child has joint pain, child never gives you this history, severe joint pain. And diagnosing chikungunya or not diagnosing chikungunya, like instead of me, if my name is not Paresh and it is Ramesh, what difference does it make?
Yeah.
There is no treatment that you need to do. You have to just give symptomatic treatment. It is self-limiting, doesn't need ICU care ever. So where is the problem? You can do, there are tests available. But the problem with these tests are also they are, I don't know, reliability. Done in only some labs. And then it comes positive sometimes really late. So by then child is all right anyway. Who's going to prick a child?
Right, sir. Right. There is some question from Dr. Vinay, and he says that since children have very small fingers, how to measure with a pulse oximeter?
So now these pulse oximeters that are made for adults, they are all made in one factory in China. They are all different names. One is Ramesh, one is Paresh, one is Suresh. They are all the same, but they are not made for babies. So you get very problematic. Sometimes, you'll have to go to a place like here to see it because we have those probes which you can tie with a Velcro strip.
Yes.
That's why. So like the baby who's 9 months old or 10 months old, thin, 8 kilo baby, that pulse oximeter that we use for ourselves doesn't work.
Right.
Also, when it does work, please give it 2 minutes.
Yeah.
The child cannot move, which is impossible. No bacha can stay without moving. Very difficult to do a pulse ox in a little baby. Bigger children, you can tell them, don't, move your finger, beta. that one can work.
Right, sir. Right. Another question from Dr. Soni is that scarlet fever has strawberry tongue. Then how to differentiate?
So scarlet fever is again a very old name for streptococcal infection. Scarlet fever children are very toxic. They are very sick. And then treatment doesn't differ from an tonsillitis standard treatment. So you can give an amoxicillin, amoxiclav combination. But a CRP will be really high.
Okay.
And how to differentiate Kawasaki? Because it will get better in 2-3 days of just an antibiotic. It will get better. You can do an ASO kind of titers and all, but these are all very academic kind of things. I don't know whether people really want to do it. But yeah, that helps, ASO.
Right. What is the best treatment for small infants? Dr. Kishore, I think you need to be more specific.
Small infants.
What
So when
is
you
the
say
best?
infants,
No,
little
it's
problematic.
the best thermometer for small
Oh
infants.
my God. So now thermometers again a big problem. So now we have got those forehead thermometers and we got those. When you use these ear thermometers, which the West uses a lot,
Right.
they give you core temperature, which Shruti will tell you. So that's very scary.
Yeah. Yeah.
Like if I take my temperature just now in my underarm, it will be 98.1.
Right.
If Shruti takes it in the ear with the ear thermometer,
yeah,
it will be 100.
Right.
So then that scares you. So if a child has 101 fever, it will show 103.
Yeah.
So that really freaks out parents.
Very true.
I myself, I'm never too anal and very particular. You must bring your temperature charts, and I'm actually against all that. If the mother will touch the child and tell me, "Gara garam hai," I mean, I believe her. To me, 103 and 101 are the same.
Right, sir.
It's the cause that is important.
Yes.
So there are digital thermometers which you keep in the underarm. That probably works best for a child. You can hold the child like this and do it. But then again, temperature or no, I don't know.
Yes, sir. I think that is all. Dr. Vaishali, I think you have raised your hands. Is there anything you want to ask directly? You can unmute yourself and ask. Dr. Vaishali, do you wish to ask something? Okay. I think that's all. We don't have any more questions. Thank you.
Thank you, everyone, and I hope that I have helped. I don't know, really. I think everything that I told you, you already know.
Yes, sir.
Just, brought it in front so that everybody just gets a little conscious of this. And because this is monsoon, just now you must all have seen a rise in number of people coming. There's lots of fever. There's, some schools in South Bombay were closed for 7-8 days. So non-dengue, non-malaria, non-COVID, very high fever for 3-4 days, little low counts, and then everybody, so they just closed down schools. But then that's okay. Schools are overrated.
I think thank you so much, sir. Thank you so much for the wonderful talk. Yes, thank you so much. And it was really, really useful. I think we all know everything about fever for a while now. Okay, now I'll like to introduce our next speaker, Dr. Sarita Bhagwat. She's one of the eminent pediatric surgeon attached to SRCC. She has an experience of over 25 years in the field of pediatric surgery. She's done her MBBS post-graduation in MCH from St. GS Medical College and KM Hospital. She has expertise in various tracheoesophageal cleft repair surgeries, repair of exostrophy bladder, epispadiasis and other surgeries. She is also a recognized teacher at Maharashtra University of Health Sciences for the MCH degree in pediatric surgery. She has contributed to various chapters in the book, and she has been a co-editor of the book Redo Surgery in the Children. She has been invited as a speaker, as a guest speaker in various national conferences, and has delivered many nice presentations in numerous national and international conferences. She's taken various research projects with her students as a dissertation submitted for MCH. I would like to request Dr. Sarita to present her talk on antenatally detected abdominal cyst. Dr. Sarita, are you there with us?
Yeah. Can you hear me all?
Yes, ma'am. I think you really need to be a little louder because your voice is...
Okay. Thank you, Dr. Shruti. Is it okay now?
Yes, pretty
Yeah.
good, ma'am. Thank you.
Okay. Dear colleagues, thank you for joining here. And I'm going to today talk to you about antenatally detected abdominal cysts. As we all know that with the widespread use of screening sonography for during pregnancies and with increasing clinical expertise amongst our sonology and obstetric colleagues, we are picking up many of the congenital anomalies antenatally. Commonest being the renal anomalies. But today I'm going to talk to you about antenatally detected abdominal cysts. So I was trying to go through the literature and find out some data for this presentation. And I would like to go through two of these publications. One is from the UK and the other is from the Chinese group. Both are single institution data. That means the entire study is done in a single institution. And there were around 80 cases in UK group and 41 in Chinese group. Now, in the UK group, of the 80 cases, 10 ovarian cysts and 1 miscellaneous cyst lost to follow up, thus leaving 69 cases. And they were followed up serially with sonographies. And of these, the classification mentioned in these two papers, as you can see here, that almost 50 to 56% of the antenatally detected anomalies of the abdominal cysts are ovarian. The second is intestinal duplication cyst, that constitutes 18%. Choledochal cyst again comes very high, 4%. And others included mesenteric, liver, suprarenal cysts, and other things. So main and most important, more than half of these antenatally detected abdominal cysts are ovarian in origin. So right at the outset, let's see what information do we need from a sonologist when we talk about intra-abdominal cyst. We should know the site of the cyst. See, you are seeing through the mother's abdominal wall, through the uterine wall, through the amniotic fluid into the baby's abdomen. So several layers of to be crossed over by the sono sounds, and the site of the cyst will tell us some idea as to what can be a differential diagnosis. Remember that in the fetus, ovaries are barely visible. You cannot identify them on normal ovaries are rarely visible and identifiable on ultrasound. So then how do you say that this cyst is ovarian cyst? So it depends on the site of the cyst. If the cyst is located in the lower abdomen and it is next to the bladder, then the sonologist can definitely see the sex of the child and decide whether this is a ovarian cyst, with always a differential of intestinal duplication cyst and a mesenteric cyst. Now, as you know, that PCPNDT Act does not allow the sex of the baby to be revealed. But if there is an anomaly which is pertaining to a particular sex, that can be mentioned in the sonography report along with other differential diagnosis. So here we do get many of such reports whereby a lower abdominal cyst, which is next to the bladder, it is mentioned that one of the differentials is intestinal duplication, mesenteric cyst, and ovarian cyst. Now, when the family comes with such a report, you can discuss these differentials with them. Another is if the cyst is located, say, on the right upper abdomen, then you can talk about duodenal duplication, choledochal cyst, or liver cyst, or perhaps a suprarenal cyst, adrenal cyst. Okay, so site of the cyst gives us a clue, and the sonologist will definitely help us with that. Size is important because every single sonography report that comes, we don't rely on only one finding. We want to know the trajectory of the cyst, whether it is increasing or it is decreasing, whether it is undergoing some changes or some more information we are getting as the size of the baby and the cyst increases. So serial estimation of the sizes is important. Now, some of them are very thin lined unilocular cysts, whereas certain cysts are thick. In the gut, you get mucosa, submucosa, muscular layer, and the serosa. So these layers are seen as alternating hypo and hyperechoic structures, and this is called as the gut signature sign. Now, suppose a cyst to start with was a single nice thin layer cyst, and then it gives you a gut signature sign. Yes, it can be a gut duplication cyst, but it also can mean that has the cyst undergone a torsion. That is why it has caused some inflammatory changes, and you are getting this gut signature effect. Same is the case with debris in the cyst. If there is a debris seen as low-lying echoes in the cyst, you wonder whether there has been a hemorrhage within the cyst. Fluid in fluid level. As this bleeding settles down, the clot settles down, it will give a fluid in fluid level within the cyst, and this is called as hemorrhage or torsion. This is known with hemorrhage or torsion of that cyst. Now, other things are also important. Suppose this is meconium cyst. Many of them, more than 85% of them, will show calcification. So with that meconium cyst, you would be interested in knowing whether there is associated intestinal dilatation, is there any associated ascites, and what are the other anomalies that are there. Let us see what are the common differential diagnoses of intra-abdominal cyst in a fetus. So as I told you, it does not give you that this is an ovarian cyst. It is the lower abdominal cyst, which is next to the bladder and in a female baby. So the sonologist is suggesting you as ovarian cyst. Now, ovarian cyst, as we have seen that it is common, 50 to 56% of the intra-abdominal cysts are ovarian cysts. And if you consider pregnancy-wise, then 1 in every 2,600 pregnancies will be detected to have an ovarian cyst. What is the natural history of these ovarian cysts? We'll look into it a little later. Let's see what are the other differentials. Now, intestinal duplication cyst. Intestinal duplication cyst, as you know, that intestine developmentally is forming as a solid cylinder. There appear small vacuoles within this cylinder, and these vacuoles coalesce to form a pipe. So a solid cylinder forms a pipe with a lumen. That is how the intestine develops. Now, suppose some of the vacuoles coalesce but do not communicate with the main lumen of the intestine. That forms a duplication cyst. And everything can have a duplication. Stomach has a 4%. Duodenum has 6%, jejunum and ileum has 53% maximum number of duplication cysts, and colon has 18% of duplication cysts. Usually colonic duplications are also associated with renal anomalies and with vertebral anomalies with perhaps anterior meningocele. So hindgut duplications, always the sonologist will provide you more and more clues, or you will ask for these clues to counsel the relatives and also to be prepared to manage the baby when the baby is born. What is meconium cyst? Fetus can have intestinal perforation de novo or because of distal obstruction or because of some vascular accident to that segment of the intestine. So this results into leak of the meconium into the peritoneal cavity of the fetus, and this invites lot of inflammatory response. The inflammatory response will be seen as thick walled cyst, irregular cyst, gut signature sign. There can also be associated ascites. If it results into intestinal obstruction, proximal gut will be dilated, distal will be collapsed, or sometimes it may result into what is called as atresia, intestinal atresia, if segment of the intestine just disappears from there. So meconium cysts, 85% of them will show calcification within the cyst wall. So this will clinch your diagnosis or will guide you to think of this. Now, babies with meconium cyst, they will manifest very soon after birth and they will require intervention. So the sonologist is priming you and the family that look, there may be this condition called meconium cyst and be prepared. What is mesenteric cysts? Now, mesenteric cysts are rare cysts. They usually manifest in adult life, though this may start as fetal conditions. Similar is a lymphatic cyst. Lymphatic cyst, you are more aware, like cystic hygroma. If it is happening in the intra-abdominal cavity, it is from the retroperitoneal lymphatic sac that some of the lymph spaces get secluded and they form a lymphatic cyst. Usually, lymphatic cysts manifest early, causing intestinal obstruction or volvulus, whereas mesenteric cysts manifest very late in life. Now, if it is a upper abdominal cyst, depending on right or left, we have a certain differential diagnosis. Of course, adrenal hemorrhage can give rise to a cyst which will be on either sides. Now, choledochal cyst is a cystic dilatation of the common bile duct. It is more common in female babies, but it is seen that way. It is quite rare. 1 in 1.5 to 1 lakh of live burns is the incidence of the choledochal cyst. Why is the common bile duct wall so thin that it becomes into a cyst? It is because of some distal problem. The pancreatic duct and the bile duct, they join. If it is a long common channel, there can be reflux of the pancreatic juices into the bile duct, and that causes weakening of the bile duct, which may have cystic or fusiform dilatation. So that is type 1 choledochal cyst. You have several types, type 1, 2, 3, 4, 5. 2 is diverticulum, 3 is choledococele, 4 is multiple extra hepatic, and 5 is with hepatic fibrosis. Close differential to this, choledochal cyst is usually in relation to the hepatic artery. The sonologist will pick it up in cyst in relation to the hepatic artery and will then trace it to gallbladder and intrahepatic bile ducts, and then he will come to know. Associated with choledochal cyst, if the intrahepatic bile radicals are dilated or not is an important thing. So many times we get babies who are born with choledochal cyst, and soon we get them investigated, and because we need to operate them as early as possible, and still in spite of neonatal surgeries also, so many times we tend to find liver cirrhosis in such babies. But not all of them are cirrhotic. So early intervention is needed as when choledochal cyst is found. Now, another thing is duodenal duplication cyst. Very closely associated organ to the common bile duct is the duodenal duplication cyst, which I told you in the intestinal duplication, it forms 6% of the intestinal duplication cysts. Okay. So in this duodenal duplication cyst, you will have a cyst which is in relation to the portal vein. Another which is very rare cyst is a liver cyst. The liver cysts tend to decrease in size over a period of time, and then they tend to disappear also, involute also. Sorry. Very few liver cysts are there which grow very big in size. They grow very big in size, and then they will be requiring some kind of investigations like MRI, fetal MRI, or something like that. But most liver cysts will regress in size over a period of time. Another thing I told you is adrenal hemorrhage. In fetal life, adrenal glands are as big as the kidneys. Adrenal glands are as big as the kidneys, and hemorrhage because of various stress factors to the fetus can result into adrenal hemorrhage. Within 2 to 3 weeks after adrenal hemorrhage, we will find on sonography that an adrenal cyst has developed. This just requires close follow-up and monitoring, because most of the adrenal cysts will decrease in size and will disappear. A close differential, if it is increasing in size, should be kept in mind of a cystic neuroblastoma. It is a very rare thing, but if the adrenal cyst is increasing in size, any cyst which is increasing in size, and especially more so in the adrenal area, it requires investigations. Now, actually speaking, renal cysts are retroperitoneal cysts. They are not part of intraabdominal cyst, and any sonologist will be able to pick up a renal cyst. Perinephric urinoma collections. These are large collections, especially seen in patients, babies with PU valves, and also in prune belly, where there is a urethral atresia with lot of reflux and urine leaks from one of the fornices in the kidney, and there is a perinephric urinoma cyst. Another very challenging thing is cystic teratoma and fetus in fetu. As you know, it develops from totipotent cells and usually in the retroperitoneum, but can be anywhere. When we are talking about intra-abdominal cysts, let us talk about cystic teratomas in the abdomen. They are actually seen cystic teratomas. It is a big spectrum. On one side, you have immaturity, so it is a teratoma, and on the other end of the spectrum, same spectrum, is a very well-formed baby, and it is called as fetus in fetu. We'll talk about it a little later. So once the parents receive this report of abdominal cysts, they will usually go back to their obstetrician, who will refer it to the appropriate pediatric surgeon or neonatologist. And usually counseling is usually done with neonatologist, pediatric surgeon, perhaps a geneticist, and of course the obstetrician. What are the common questions that the parents ask? What is the site of origin? Is it going to grow significantly? So only serial sonography is going to tell us. If it is growing very slowly, we do not need any antenatal intervention, because intervention is not without complications. And we are just by the sheer sight of the cyst, we are giving a differential diagnosis. So there is no need to intervene antenatally unless there is massive increase in the size of the swelling of the cyst, which suggests that it is not one of the common cysts, and it definitely requires further investigation. If it is so rapidly increasing, then definitely there is a need for a fetal MRI, and then from there we will take it on. Now, where do we deliver? Say simple commonest thing is the ovarian cyst. If it is a small ovarian cyst, even if it is complex or simple, it can be delivered in their hometown. A neonatologist should attend all the babies born and should examine them thoroughly. If there is a mass found, definitely there will be a pediatric surgical reference. And if there is no mass found and everything looks fine, the neonatologist will start the baby on feeds. Whenever any abdominal cyst is diagnosed and the baby started on feeds, things to watch out for is abdominal distension and whether the feed intolerance is there or not. So if the baby is vomiting, or whether the baby is tolerating the feeds. If the baby tolerates the feeds, let the baby go home with the mother on day 2-3 of life, and then we'll come back for follow. Now, is there a need for cesarean section? This is usually decided by the site and also the size. A 5-6 centimeter cyst, or even to that extent 10 centimeter cyst, if the sonologist and the obstetrician is comfortable, can be delivered vaginally, and that is not an indication for cesarean section. But when it is a rapidly increasing abdominal cyst which has required antenatal MRI and all that, then those things are different. They will guide you to do a cesarean section. So as I had discussed with you all, that at birth, neonatal examination is a must. So is that person will make a surgical reference. And if there is no distension and the baby is tolerating the feeds well, baby will be discharged with the mother, and follow-up sonography is called for at around 3 weeks of age, and pediatric surgery consult is arranged. Now at home, what are the red flag signs? If the baby has feed intolerance, starts vomiting, or has sudden onset excessive crying, suggesting that there can be a twisting of the cyst, or anything unusual that the family notices, they notice a large abdominal lump while bathing the baby, then they should inform the neonatologist and look for a admission and pediatric surgery consult. Now, what is the natural history of ovarian cyst? As we know, 50 to 56% of the intra-abdominal cysts are ovarian cysts. These are usually follicular cysts or simple cysts. What does it mean? If you see the fetal ovary or the newborn ovary on ultrasound, you can see multiple cysts. So these are under the influence of mother's estrogen or placental human chorionic gonadotropin (HCG), or very rare, occasionally under the FSH of the fetus. So they are present in many of the babies. A simple cyst is thin walled, has clear contents, no debris inside, usually less than 5 centimeters. Okay. Whereas a complex cyst has gut signature or irregular wall, has debris inside, has fluid in fluid level in the cyst, and these are suggesting of complex cyst. What does it mean when you say that it is a complex cyst? Usually complex cysts either have had hemorrhage within the cyst, or it has that ovarian cyst has undergone torsion. Now, whenever fetal ovarian cyst undergoes torsion, it is a complete torsion, and no identifiable follicles also are found. When we explore them post surgery, post birth, hardly any tissue is found which is viable. So intervening at that age is out of question. That is why I said no antenatal intervention in such ovarian cysts. But even postnatally, because it has already undergone torsion, there is no need for a urgent laparotomy or laparoscopy to be undertaken. Now, what do we do with simple cysts? So if it is a simple ovarian cyst, say less than 5 centimeters, you ask for a follow-up ultrasound at 3 weeks, 6 weeks, and 12 weeks, and at 6 months. That is 3 months and 6 months. 3 weeks, 6 weeks, 3 months, 6 months. What are you going to see? During this period, you will see whether the cyst is decreasing in size. As the maternal hormonal influence and placental hormonal influence wears off, there will be decrease in the size of the cyst, and this ovary will come back to normal. Okay, this is the natural history. Always you will remind, during every visit, you will remind the family about the red flag signs, that if there is a lump palpable, if there is feed intolerance, sudden excessive crying, then they have to report back. Why this figure of 5 centimeters? Now, it is observed in large studies that more than 5 centimeters, if the cyst is more than 5 centimeters, then because of the sheer weight, the chances of torsion are little higher. And hence, previously it was stated that more than 5 centimeters and it is better to at least deflate the cyst. Now, this has also in the recent publications, it has been challenged, and there are several papers where 6 and 7 centimeters cysts over a period of follow-up ultrasounds have regressed in size and they have disappeared. But at the same time, when you talk to the relatives about this, you have to give them both the options, that you can observe patiently, or if you are not willing to observe patiently and do not have that much patience, then perhaps we can offer you aspiration of the cyst. Now, aspiration is also offered for complex cysts. Now, what do you mean by aspiration, and why aspiration? Why aspiration of the simple cyst and why aspiration of the complex cyst? Now, aspiration will just decrease the tension within the cyst and allow it not to rotate just by sheer weight of the cyst and size of the cyst. It can be done under sono guidance, or it can be better done by laparoscopy. Why sono guidance? Why sono guidance is also going to require anesthesia to the baby. Why not use that opportunity to put in a laparoscope so that you can see what is the site of origin of the cyst. You are 100% sure that it is ovarian cyst. You will see the other side ovary being normal. Even if this ovary has undergone torsion, you can do is it auto amputated with absent adnexa, which is also very common. It gets auto amputated. The ovarian cyst which has undergone torsion, it gets auto amputated and it starts moving in the abdomen. So one ultrasound it will pick up in the lower abdomen, the other ultrasound may pick it up in the upper abdomen. Okay, so you come to know whether it was ovarian cyst by seeing that there is absent adnexa on one side, whereas the other adnexa is normal. Now you can also have a look at other organs in the abdomen. So anesthesia which is given for aspiration is optimally utilized by putting in a laparoscope. Okay, so that is how you manage. Now, what are the surgical options? Whenever there is a simple cyst, we don't tend to remove the cyst. These are follicular cysts. So we just puncture, aspirate the fluid. If at all make multiple punctures, that cyst itself in the wall will have lots of ovarian follicles. So partial excision of the cyst is also nowadays not recommended. If at all, you may just incise it and leave it open like marsupialization, and that will cause some amount of adhesion, so it does not undergo rotation. At the same time, most of the ovarian follicles are preserved. So the reasonable indications for surgical intervention include increase in the size in the postnatal period, symptomatic cysts, non-resolving cysts after a period of observation more than 5 centimeters, non-resolving complex cysts. Even a complex cyst in some of the series, they have shown that they decrease in size and almost involute and disappear. But if it is a non-resolving cyst, even at the end of 6 months of observation, then this cyst can invite some adhesions, and these adhesions can result into intestinal obstruction. And hence, it was thought that it is better to undergo surgical intervention. But there are contrary reports also nowadays in the literature that not all these complexes invite adhesions, and they can involute without causing much problems. At the same time, when I tell you all this, red flag signs have to be informed to and reconfirmed and reassured to the parents that if there are red flag signs, they cannot keep the baby at home and they have to rush to the hospital. The guiding principle of this surgical procedure that I described you just now is ovarian preservation and avoidance of unnecessary procedures. So what are the key factors in deciding what is to be done? So trajectory of the cyst behavior, whether it is increasing or decreasing or changing the characteristics of the cyst wall and the contents, and ultrasound findings after birth. These are the key factors to determine what is going to happen to this cyst. And the parents are well informed about these consequences and they are allowed to choose an option of their choice. So this is an antenatal scan, old case. Antenatal scan of the lower abdominal cyst next to the bladder. This baby was referred to me on day 2. At 34 weeks, the cyst was 52 by 48 by 47, and it was already showing a gut signature sign. There were internal echoes. By 36 weeks, there was fluid in fluid appearance on the ultrasound film, and it had marginally remained same in size. Now this at the time of birth, it was a vaginal delivery. The obstetrician asked for an ultrasound on day 1 of life because the parents were also insistent what is the pathology. So it was thought to have decreased in size with 44 by 41 and 40 millimeters. But knowing that it was a complex cyst, though it was less than 5 centimeter in size, it was a complex cyst because there was fluid in fluid level, gut signature sign, there were debris. So suggesting that the baby has already undergone a torsion of that intra-abdominal cyst. At 3 weeks of follow-up, the cyst has marginally increased in size and the parents decided to go for intervention. They decided to go for open intervention many years back, And this you can see, this is the fallopian tube and the femoral end, and this is a totally it has undergone torsion. Okay, next. So this baby also was detected to have antenatal sonography, a lower abdominal cyst, and it was next to the bladder. It had shown a gut signature sign. So it was thought to be one of the differentials. The baby was started on feeds and did not manifest anyhow, so it was sent home. But the smart family members noticed this lump at around 15 days of life, and they came for intervention. You can see this mass here. On plain X-ray, you can see this soft tissue swelling. This is the hand of somebody with a ring there. This is not a calcification. This is a soft tissue mass. And this is on ultrasound. Okay. You can see the gut signature sign here. Alternating hyper and hypoechoic layers in the abdomen, in the cyst wall. This is gut signature. And what it turned out to be is a intestinal duplication, ileal duplication. You can see the cecum and appendix, and this is the terminal ileum. And you can see on the Meckel's is on the anti-mesenteric side. Duplication side, cysts are on the mesenteric side of the intestine. And this is a stretched out ileum. And you can see this is the cyst. A small resection anastomosis was performed, and the baby went home uneventfully. This is again antenatal. Only one sonography was there which picked up a double bubble sign and query cyst in the duodenal region in the upper quadrant. The family did not go ahead with any of the sonographies. They were staying far away and did not go for any of the sonographies thereafter. The baby had a normal vaginal delivery, was started on feeds and went home on feeds. On day 4 or 5 of life, had bilious vomiting and came back. And the neonatologist had done, they said baby was passing stools, baby was feeding well. So he was saying there was a double bubble and some cyst in the upper abdomen. So he did a barium, and you can see one actually X-ray shows this air fluid level and this air fluid level in the duodenum, but there is distal gas, and this is a duodenal web. This what was thought of as duodenal duplication was not a duplication. Actually, it was a duodenal web with a central hole. So things were going across, but at the same time, because of fenestration, there was some partial obstruction, and duodenum had bloated up. The baby underwent Kimura procedure and had uneventful recovery. So this is another case, intra-abdominal cyst in the center of the abdomen, moving on repeated sonographies, not much increase in size, but postnatal scans started showing increase in size, and baby had on and off crying episodes. X-ray was not very sure, but sonography picked up a cyst, and on opening, this is a chylolymphatic cyst. This is a lymphatic cyst in the mesentery of the intestine. And as the baby is put on orals, because of the fats in the breast milk, it becomes a chyle. Chyle is taken into the liver from these cysts, and these cysts do not have much more communication with the rest of the lymphatics, and that is why this has formed a chylolymphatic cyst, very common in the jejunal mesentery. And if you can get rid of the cyst without touching the jejunum, it will be great. Otherwise, it may require a small resection anastomosis. Now, let's go to something interesting. This is a 31-year-old mother, G3P1L1, who at third trimester ultrasound was told to have a right upper abdominal cyst in the fetus. The cyst was very tiny at that age, 3 by 2.4 centimeters at 28 weeks of gestation, and it was arising from the head of the pancreas. Okay. Where there were thin septations and echogenic material. So the differential given to the by the sonologist were either entering duplication cyst or a neuroenteric cyst. That means there is a communication with the spine as well. That is a neuroenteric cyst. Now, previous sonographies at 7 weeks, at 12 weeks, at 19 weeks were within normal range. They reviewed the sonography films and they could not find this cyst, which was picked up at 28 weeks. She underwent every 4 weekly, she underwent sonography. And as you can see, at 32 weeks, the cyst had increased 3.9 by 2.8, and at 36 weeks, 5.5 by 4 by 3.1. Also, the characteristics of the cyst changed. There was intracystic calcification. Now, remember, meconium cysts have calcification within the wall of the cyst, whereas this were intracystic calcification. So, the contents of the cyst, there was calcification. At term, the mother had a normal vaginal delivery and the baby cried immediately after birth. On day 2, the sonography was repeated by the neonatologist. And it showed that there is a right retroperitoneal large cyst, 6.9 by 3.5. It was subhepatic and it was pushing the right kidney anteriorly. So it was behind the kidney in the retroperitoneum below the liver. And those calcifications within the cyst turned out to be few vertebrae, and at least one femur and one humerus was well identified by the sonologist. So what does this mean? This means that this is fetus in fetu. What is fetus in fetu? It means it is an extreme, as I told you, teratoma is very immature elements. Once there is an axial skeleton, that means at least one vertebra and one limb bone, and other organs are organized around this axial skeleton, then it is justifiable to call it as a fetus in fetu. And then why does it appear as a sac? That cyst is an amniotic cyst. So how does it form? It is a monochorionic monoamniotic twin. And because the twins share their vitelline circulation, one twin goes into the other. Now here, as the story will unfold, it gets a supply to a certain extent, and beyond that level, it does not get any supply from the host twin, and then it actually dies off. Okay, so the fetu is a dead fetus inside the live fetus. Okay, so parents decided not to do anything, and they took the baby home. They already had an elder son. So they took the baby home on day 3 of life and they sought several opinions. They had decided, when they came to me, there was an upper abdominal fullness, ill-defined cystic mass, very ill-defined, rather flaccid. And they had decided that they will celebrate the first month birthday of the baby and then they will come back for intervention. So as they decided, they came back on day 31. We got them admitted here at SRCC. We got all the baseline investigations. This alpha fetoprotein value is within normal limits. At birth, it runs into thousands, and with each day, it comes down drastically. So there are nomograms available, and you have to match the baby's age with that nomogram. And this alpha fetoprotein level is within the normal limits. So once we got the creatinine level normal, we got a CT with contrast done to know the anatomy. You can see this is a subhepatic cyst. It is pushed the kidney anteriorly and the adrenal anteriorly. You can see post contrast, this is the IVC and the aorta is on that side. So the cyst is lying between the IVC and the aorta. It is stretching both the major vessels away from each other. And these calcifications are not the dye; these are the intracystic calcifications, which tell you that this is the vertebra and one of the 2 of the limb bones. This is again MIP images. You can see the portal vein and superior mesenteric axis, and this is the kidney. These are the common iliac aorta bifurcating into common iliacs. So aorta is on this side. This is the IVC. So between these two, this cyst has played the distance between the IVC and the aorta, and you can see this calcified bones within the fetus in fetu. So let me take you through the journey of this very thrilling journey of this challenging case. We got the baby admitted. Dr. Nandini, as you know, she must have spoken to you some time back, the anesthesia team leader, and she gave the anesthesia. We had a arterial and epidural line and central line, and we took this is the head end of the baby to orient you for this thrilling presentation. Head end of the baby, this is the foot end of the baby, and abdomen, that is the umbilicus, this is the jiffy sternum. So we take a horizontal incision in babies, supra-umbilical horizontal incision, and we have opened this. So this is on the right side, that is on the left side. This is the head end. This is the liver retracted. You can see the adrenal as big as the kidney, and this is the loop on around the IVC. Okay, and this is a cyst. This is the amniotic cyst. Okay, within which lies the fetus in fetu. Remember, amniotic fluid is extremely irritant, and this cyst should not rupture, because that amniotic fluid will cause dense adhesions in the bowel thereafter, and will come back again and again with adhesive intestinal obstruction. So the thrill was to not deflate the cyst, not rupture the cyst, but to deliver it intact in toto. So this is the IVC. You can see the left renal vein joining the IVC, and it is very closely, associated with the cyst. You can, when we were palpating the cyst while retracting, you can feel the inside bones of the baby and the baby. Okay. So we first cauterized the duodenum, took down the hepatic flexure to cauterize the duodenum. Then we separated it from the liver. Then we have separated it from the left renal vein we identified and separated it from there. Then the lesion was going behind the right kidney and right adrenal. We mobilized that part and got it on the medial side. So the right side was totally separated. Then we went on the back wall to see for the right renal artery and adrenal artery, which goes behind the IVC. So here you can see we are defining those vessels. Okay, so this is the adrenal. This is the adrenal artery, right renal artery. This is, now you can see the left renal vein. This is the right renal artery, right adrenal artery. Okay, this is the left renal artery. Now the cyst is almost out. You can see the cyst is almost coming out here. While defining the left renal artery, you have to be careful about the superior mesenteric artery, because the angle between the superior mesenteric artery and the aorta is traversed by this left renal artery. So we protected it, and the specimen is out. This is for you to identify. This is the IVC, left renal vein, right renal vein. The aorta is here and the IVC is here. They are not together because of the cyst occupying that space. And this is the right suprarenal artery and right renal artery arising from the aorta and going behind the IVC to supply this large adrenal. At this age, it is that large, and hence hemorrhage in the adrenal can form a large cyst. So this is a large adrenal, almost same size as the kidney. Okay. So this baby had an uneventful recovery. He required 1 unit of blood, of course, because HB dropped to 8.7, and had on day 3, baby had some occult blood in the stool positive. So we waited for 1 day and then started feeds. By day 5, baby was started on breastfeed, and baby was discharged on 7th post-op day. They came for a 1-year follow-up after the child has become 1 year old now, and baby is doing very well. This was the cyst, amniotic sac. And when we took an X-ray, you can see the axial skeleton, you can see the vertebrae and the limb bones. These 2 bones means forearm or leg, or lower leg, and this single bone is a arm, or you can see even the pelvic bone. Anencephaly is very usual with these babies. So I cut open the amniotic cyst, and you can see the limb buds. You can see anencephaly. This is the open neural tube there. These are hair on the head, and you can see the digits, early digit formation. 20 years back, I had done one more fetus in fetu, and that time the feeder was in was one of the branches of the celiac artery, and this time it was a superior mesenteric artery. And that time I had to dissect between the portal vein and the IVC, and here it was IVC and the aorta. And these were the pictures. You can see nicely calcified skull and limb bones in this baby's X-ray, host baby's X-ray, and this is how the dissection went on. And this is the post-op specimen with limb buds, anencephaly again, some gut herniated. Okay. Thank you. Over to you, Shruti. Shruti?
Yes, ma'am, we are here.
Yeah.
Do we have any questions for Dr. Sarita? Thank you so much, ma'am. That was a really extensive presentation.
Sorry, I hope I've not
No,
exceeded the
you have
time.
not crossed the time. You're well on time, but it covered quite a lot of things which were very new to us. So amazing presentation. I would request if anybody has any question, you can post it on the chat or you can just unmute yourself and ask. Anybody has any question? Dr. Naveen, you have raised your hand. Do you wish to ask something?
No, thank you. It was wonderful. I had raised it earlier for the earlier lecture, but it's okay. Thank you.
Okay. I guess that's all, Dr. Sarita. They've
Okay,
understood
thank you.
everything. Thank you so
Thank you.
much. Yeah. Okay. Can you guys see my screen? Hello?
Yes, madam.
Am I audible and can you see me? Dr. Hiren, are you there? Hello? Can somebody tell me if my screen
Yes,
is
madam.
visible?
Audible and visible.
Okay.
Yes.
So the next presentation is by me. I am Dr. Shruti Bansal. I'm the ENT consultant at SRC Children's Hospital. And I'll be talking on a very basic topic, which is adeno-tonsillar hypertrophy. But what we are going to discuss today is a changing outlook towards a patient with these adeno-tonsillar enlargement. So what are adenoids and tonsils? Tonsils and adenoids are basically a group of lymphoid tissues which are present in the throat. They are a part of a Walder's ring, which is a ring of a lymphoid tissue present around the oropharynx and the nasopharynx. They comprise of palatine tonsils, which are more commonly known as tonsils, lingual tonsils, which are present at the base of the tongue, tubal tonsils, which are present around the eustachian tube, and nasopharyngeal tonsils, which are present at the back of your nose or nasopharynx, more commonly known as adenoids. The primary function of tonsils and adenoids is to produce B lymphocytes and T lymphocytes, thereby playing an important role in both cellular as well as humoral immunity of the body. So basically, these tonsils, adenoids are believed to be first line of defense against the microbes that enter the body via nasal and the oral route. So what happens is that normally the tonsils and adenoids are present in every child or every person when they are attacked by various bacteria, various germs or various viruses. What happens is that there happens an antigenic stimulation, which may be acute or chronic. This leads to production of antibodies both locally as well as systemically. This is what happens normally, and this is what is the function of tonsils and adenoids. But what happens is whenever there is any inflammation, infection, or allergy, it leads to excessive hyperplasia and hypertrophy of the lymphoid follicles, leading to various degree of oropharyngeal and nasopharyngeal airway obstruction. That is where the problem arises. Okay. So these are how the enlarged tonsils and adenoids look. The picture on your right side are the enlarged palatine tonsils or the big tonsils, which are causing the oropharyngeal obstruction. This is what is seen in the sagittal view. Adenoids are present at the back of the nose or at the nasopharynx, and when they enlarge, they causes obstruction in the region of nasopharynx. What are the symptoms of a patient with enlarged tonsils and adenoids? The most commonly presented symptoms are fever associated with sore throat, pain or difficulty in swallowing. They may have enlarged lymphadenopathy or glands in the neck. They may present with a cold, blocked or stuffy nose with or without discharge, sometimes difficulty in breathing. Some patients may only present with ear complaints, which may be in the form of blocked ear, fullness of the ear, pain in the ear with or without discharge. Some children may also have impaired or decreased hearing due to accumulated fluid in the ear or impaired eustachian tube function. Children may also present with a sleep disturbed breathing. When we call the sleep disturbed breathing comprises a myriad of symptoms, which includes snoring, mouth breathing, upper airway resistance syndrome, and sometimes obstructive sleep apnea, all of them leading to upper airway obstruction. These children, because of the chronic sleep disturbances, may also have a neuropsychiatric effects, which may be seen when they as a behavioral issues. Chronic upper airway obstruction may also lead to cardiovascular symptoms. So what happens is the body has an immense capacity to overcome these symptoms. So these children continue to tolerate the obstruction, and as a result, they may develop chronic obstruction leading to cardiovascular symptoms. In extreme cases, it may be in the form of heart failure. In milder cases, it may present as a strain on the heart or even the arrhythmias. Also, the chronic airway obstruction or chronic obstruction of the upper airway may lead to stunted or the impaired growth. Some children may also present with enuresis and bedwetting, and all these symptoms are primarily because of the disturbed sleep. So there are various articles which have been published, which says what is the effect of the sleep disorder breathing on the hormones, and it clearly says that patients with sleep apnea have a lower level of growth hormones, and 70% of the growth hormone is secreted at night during the phase of deep sleep and slow wave sleep. So because of the airway obstruction, these children are not able to have a peaceful and a restful sleep. They keep on getting up again and again. So their slow wave sleep pattern is very disturbed, leading to impaired growth hormone secretions. So these children sometimes are referred to us by the endocrinologist because they are being worked up for the stented and the impaired growth. And then when we examine them, we find them that they have enlarged tonsils and adenoids, which is causing airway obstruction, leading to impaired growth hormone secretion and also chronic hypoxemia. There is another article which says there is a paroxysmal activity and seizures associated with sleep breathing disorder in children. So what happens is, because it is not that airway obstruction is the cause of seizure, but what is important for a child who has an elliptogenic potential is to have a nice peaceful sleep at night. A disturbed sleep at night or a hypoxemic sleep at night can lower the elliptogenic potential, leading to increased frequency or duration of the seizure activity. So quite a lot of our children who have an underlying seizure disorder with an associated enlarged tonsils and adenoids, when they undergo a surgery for the same, the symptoms decrease both in duration and frequency. So according to this article, there has been an exacerbation of seizures which could be related to the sleep fragmentation and instability due to sleep respiratory events or hypoxemia. So there is enough evidence available now on the published articles, which says that the tonsils adenoid, the patients may not only present to you with the typical symptoms of fever or sore throat or mouth breathing and snoring. There is much beyond that which these children may experience, which may be in the form of a stented growth or even putting them at a risk of seizure activity. This is a child with a typical adenoid faces. If you see, they have an underdeveloped thin nostril. The upper lip is shorter. They have a prominent upper teeth with crowding of lower teeth. They have a narrow upper alveolus with highly arched palate and hypoplastic maxilla. So what happens is that these children are trying so hard to breathe against an obstructed airway. So the back of the nose or the nasopharynx barely has any space to breathe. So what they do is they try to compensate to breathe through it, to breathe through the mouth and the nose, leading to excessive pulling of the muscles of the face, leading to these typical faces which are known as adenoid faces. If you actually do an X-ray of the nasopharynx in the lateral view, you'll actually see that there is a huge adenoid hypertrophy, which is leading to almost 90% reduction in the airway. So this is the air column. If you trace it backward, you see that this part is completely occluded. And this is the amount of the air column that is seen. So they are practically surviving on 10% of the capacity of the airway column. So now I'll come, before coming to the indications of the surgery, what I want to discuss is what were the changing trends in the treatment of the adeno-tonsillar surgeries. So what happened in early 20s, there was an increased incidence of group A beta hemolytic streptococcal pharyngotonsillitis, and it had led to certain complications which were very fearful, including the rheumatic heart disease. Because of this, what would happen is that even if there is a recurrent infection or a pharyngotonsillitis, even in the family member, the children in the family would go a prophylactic adenotonsillectomy just to avoid these rheumatic heart disease and kidney issues. So there was an inadvertent adenotonsillectomies happening for everything that was happening to the children, or just prophylactically if there was a recurrent adeno-pharyngitis in the family members. Of course, because of the traditional methods of doing the surgery, it was associated with increased morbidity and mortality. But with advent of potent antibiotics, primarily penicillin, what happened? There was a decrease in the incidence of pharyngotonsillitis, and then there was a decrease in the incidence of rheumatic heart disease, thus minimizing the need of surgery. It was during the same time when people realize that tonsils and adenoids play important role in providing the first line of defense by giving the immunity to the child in first few years of life. So what happened is that people started deferring this surgery in children for long times, because they would think that it is not being helpful, the antibiotics are taking care, and it is associated with increased morbidity and mortality. So what happened? There were some patients who continued to suffer for a long time because of lack of understanding about the right candidate. Who is the right candidate to undergo a surgery? With the improvement in both the surgical techniques as well as anesthetic techniques, the morbidity and mortality which was associated with these surgeries has significantly reduced. So what we have to do is understand who are the right candidates. We cannot let our child suffer. So I always give an example to my patients that tonsils and adenoids are like security guards of your house. If your security guard started stealing from your own house, there is no point keeping him in the job. So you have to balance out that what is the time when adenoids and tonsils have started giving them problem, which is leading to recurrent cold and cough in the child, ear problems, difficulty in swallowing, causing hypoxemic brain injuries, and causing chronic upper airway symptoms. So what is important is that you pick up the right candidate and go ahead with the surgery in those candidates only. So now coming to the indications of the surgery. Indications include for the adenoidectomy, it is done in children with a disturbed sleeping pattern, children who develop recurrent rhinosinusitis, children with chronic secretory otitis media, or with the children who have developed fluid in the ear or glue ear. What happens is, because of the enlarged adenoids, there is blockage in the nasopharyngeal end of the eustachian tube. So all the secretions of the middle ear, which were to drain naturally in the back of the throat, gets accumulated in the middle ear. And with time, the mucus part of it gets absorbed and the glue kind of a secretions remain. This glue kind of a secretion acts as a stagnant pond water or a stagnant medium for bacteria and viruses to grow, which can lead to serous otitis media or secretory otitis media later in life. This may lead to the impairment in the hearing, recurrent ear recurrent of acute or chronic colitis, more than attacks in 1 year, more than in 2 years, more than 3 attacks in 3 years, or 2 weeks or more of loss from schoolwork. When I say there are attacks, attack means the child should present with either sore throat with at least one of the following signs, which means the patient runs a fever of more than 100 degree Fahrenheit. There is associated tender lymphadenopathy, mainly jugular-digastric lymph nodes. There can be tonsillar exudates and positive culture on the throat swab. Another indications for tonsillectomy include acute tonsillitis with febrile seizure. So if a child is having recurrent episodes of acute tonsillitis and throwing up febrile seizures, these patients become the candidate for surgery. Patients with peritonsillitis or peritonsillar abscess, more than 2 episodes becomes an indication to remove the tonsils once the tonsillitis settles down. Tonsillar hypertrophy causing airway obstruction or sleep disturbances, difficulty in swallowing or interference in the speech, and sometimes there may be a unilateral or irregular tonsillar hypertrophy with the suspicious of malignancy. Another indication includes the carrier of group A beta hemolytic streptococcal or diphtheria, chronic tonsillitis with foul taste and halitosis or a bad smell from the mouth, because the follicles of the tonsils may harbor the food particles and infection and bacteria and may lead to bad breath and bad taste in the mouth. Frequent streptococcal infection in patients with related heart or kidney disease, there's another indication to remove tonsils in them. The only contraindication these days is anemia and coagulation disorders and in active infection. Patients with cleft palate are also the one where it is contraindicated, but I will be discussing one of the case where the patient with cleft lip and palate who had undergone a repair at an early age underwent a tonsil adenoid surgery because of the newer techniques which were available. So we could preserve the velopharyngeal sufficiency in these patients without causing any damage to the eustachian end of the eustachian tube. So I would like to do a special mention about role of adeno-tonsillectomy in patients with Down syndrome. So in patients of Down syndrome, adenoids are believed to be physiologically important. It is because they have a shorter soft palate and they have a highly arched, shorter hard palate. They may have an associated submucosal cleft palate, and removing adenoids in these patients can result in hypernasality. However, if these patients are symptomatic, we need to eliminate or reduce the symptoms by removing or shaving of the adenoids just enough to remove the obstruction so that the symptoms of snoring, sleep apnea, mouth breathing gets reduced. So in these patients, we expect a higher chances of complication, and it may take longer to resume the oral intake. So we always recommend that they need an adequate hospitalization and overnight observation. So what are the current trends in the adenotonsillar surgery? So to begin with, in the past history, this was the most butchered method, I would say. It's obsolete and abandoned now, and it is known as guillotine's tonsillectomy, wherein we used a guillotine's tonsillotomy. It was believed to be an OPD procedure where the patient was asked to open the mouth, and under the local anesthesia, the tonsils were just plugged out or removed from the tonsillar fossa. It was very painful. It had huge morbidity, and the chances of bleeding were significant. However, with the newer techniques, more and more sophisticated tools have come up. Basically, we can divide the tonsillectomy methods into hot and cold methods. Cold methods include our standard, very renowned, still used method of dissection and snare, and another technique called cryosurgical techniques. What is more commonly used these days are electrocauteries, laser tonsillectomies, radiofrequency ablations, harmonic scalpel, and coblation. There is a reason why I have highlighted and made the coblation bold, because this is a thing which we use most commonly in SRCC. It's a beautiful technique. So depending upon the type, again, the tonsillectomy can be done in two ways: extracapsular tonsillectomy or a total tonsillectomy, or a subtotal intracapsular tonsillectomy, which is more commonly known as tonsillotomy. So what is the difference is that in tonsillectomy, we remove the entire tonsil, including the capsule of the tonsil. So it's an older technique. The entire tonsil is dissected from its surrounding fascia. Now, because we are removing it with the capsule, it is much more painful, and there is more chances of bleeding and injury to the structures in the bed of the tonsil. However, there are no chances of recurrence because we have removed everything. It is mainly indicated for children or in patients who complains of recurrent tonsillar infection, because you want to make sure that you're removing the entire tonsils. Tonsillotomy is a relatively newer concept which has come up. We practice it in SRCC very, very commonly. Here, what we do is we reduce the tonsillar tissue from the medial end up to the capsule of the tonsil. We preserve the capsule of the tonsil, which acts as a natural biological dressing, and the structures below it are not exposed. Therefore, the pain and bleeding is much less. However, they say the chances of recurrence are higher in this, but we make sure that we remove the entire tonsillar tissue up to the capsule. So we have not really seen a child who has come to us with a recurrence. It is mainly indicated for the children who have come with the symptoms of snoring or obstructive symptoms, difficulty in swallowing or a difficulty in talking or difficulty in chewing food, or obstructive symptoms. So what I want to say is that there are all these tools, whether it is a laser or a microdebrider, radio frequency ablator, co-ablator, harmonic scalpel, dissection snare method. These are all different tools in the armamentarium of a surgeon. It is up to us to figure out which method to use. Every method or every instrument has its own pros and cons. So we need to balance it out in every patient individually. So dissection and snare is the most commonly used method, which is still prevalent, still used by most of the ENT surgeons. Here the tonsils are removed with a forceps and dissector with the wire called the tonsillar snare. It completely removes the tonsils, and the remaining tissue or whatever the bed of the tonsil is cauterized with the help of a cautery, so as to ensure that there's no bleeding. Coming to the intracapsular tonsillotomy, which I said is a newer technique, it can be done only with the powered instruments like a microdebrider or a co-ablator. Here, the tonsils are removed by preserving the capsule of the tonsils, which I said acts as a natural biological dressing. So it eliminates the obstructive portion of the tonsil, leading to reduced post-operative pain. The recovery is much more rapid. We see children, they are good to go home on the same day, and they recover completely within 48 hours, and the oral intakes resume within 72 hours. The delayed complications are much less, which less chances of secondary and reactionary hemorrhages in these children. This is a microdebrider, which is a powered rotatory shaving device with a continuous suction. It's a very beautiful device, but I personally don't use it much because it's a powered instrument and it is cutting away the tissue. So the chances of injury to the collateral structures is much more in this. And what I use here, or what we use in SRCC, is a co-ablator. It's a very, very beautiful technique. It's like pen kind of a handheld device. It uses a field of plasma to ablate tissue. So it has an internal irrigation supply. So it combines the technology of radio frequency and saline to create a plasma field. So what happens is that it breaks the hydrogen bond by creating a plasma field between the tissues. Because there is a continuous supply of the water, the heat generated in and around the tissue is much less, to the degree of 40 to 80 degree, compared to 100 to 400 degrees in electrocautery and laser. So because of the reduced heat, continuous irrigation, the charring and scarring in the collateral tissue is much less, which leads to reduced post-operative pain and scarring. The bleeding is much less because it has inbuilt ablating or coagulation device. The healing is much faster and complications are less. So this is how a co-ablator wand looks. It's a small handheld pen kind of a device. It is 4-in-1 tool which ablates the tissue. It provides hemostasis. It has an inbuilt suction, so the field is very, very clear, and it has an inbuilt irrigation. I call it as my magic wand. So this is how a co-ablator wand looks. It's individually used for each patient. It's a disposable one-time use wand, and this is how we use it. I'm going to show you in a video. This is a surgery which we had done for one of the child. So I've already finished doing the left side. This is the right side tonsil which is enlarged, and this is how when we were trained to use the co-ablator, we were told that hold it as if you're holding a paintbrush and use it as you're brushing, you're doing a painting. So very lightly, we just, kind of touch the tissue. So this is how we do a tonsillotomy. This is a patient with a repaired cleft lip and palate with a huge enlarged tonsils and adenoids. He had recurrent episodes of cold, cough, and blockage. Nobody was willing to do a surgery in this patient because it was said that you should not operate on children with cleft lip and palate. So we decided to do a reduction tonsillotomy in this patient so as to remove the obstruction. The child is doing pretty well after the surgery. So coming to adenoidectomy procedure, adenoidectomy was still now it is done using a curettage. It is known as adenoid curate. It's called curate adenoidectomy. It was first described in 1885. This is little, I believe this is a little brutal method, but what we do is we put in a curate through the mouth and just scrape out the adenoids from the back of your nasopharynx. Sometimes some surgeons also use the fingernails to just feel and touch, see how much is the adenoid tissue. The disadvantage with this was that it was a blind procedure, so you don't know how much have you removed. It was associated with a lot of bleeding because you're practically scraping out the lymphoid tissue from the back of the nose. The removal was inadequate because for the similar reason that it's a blind procedure. Sometimes if on an attempt to remove the tissue from the lateral side led to injury to the eustachian tube, which would lead to problems in the ear, middle ear issues, fluid and pain in the ear. And sometimes because of the damage to the surrounding structure, it would lead to a nasopharyngeal stenosis. To overcome this, with the advent of endoscopes, what has come up is that you can do the same curettage under the endoscopic control. Better to do the surgery using a coagulator or a microdebrider. So the benefits of doing an endoscopic assisted coagulation adenoidectomy is the visualization is better. We are using the view is much more magnified. The collateral damage is less. The hemostasis is assured. The healing is rapid and it is associated with less pain. This is a video of a child who had undergone an endoscopic. So I've put the scope to the nose, to the nasal cavity, and I've put the coagulator to the mouth. So you see what the tissue that is completely blocking the choana, how this adenoid wand is just eating away or sucking away the adenoid tissue. It's a beautiful device. It just makes sure that everything is under vision. You are removing all the tissue that is required, and it is giving us the hemostasis at the same time. So this now I have put the scope to the oral cavity, and you can see this. These are the posterior choana, which are completely clear, and child is now able to breathe well through the nose. Yeah, thank you so much. If anybody has any questions regarding same thing, you can ask. My take-home message will only be that please see to it that you don't let the child suffer because of the age. No, there is no lower limit or upper limit before which the child cannot get the surgery. It depends upon how much is the symptoms of the child. Thank you.
Project YAML file that we just set up. Make sure that the profile is
Any questions, please? Thank you, Dr. Kishore.
Make sure that it's able to. Now, if you're getting errors part, this is one of the stuff for a fairly long time. So what I recommend is
anybody has any questions, please feel free to ask.
I would try first logging in here.
Dr. Joshi, can you mute yourself, please? Dr. Joshi, can you please mute yourself?
And make sure they have access to the warehouse, database, and schema. The other thing that you might be able to check if yours isn't working is the account. So if you have a document that says 1, 2, essentially there's any.
Anybody has any questions, please ask.
So when we run DBT run, it's actually going to try to run those SQL queries on our Snowflake. And so sometimes here you're going to find some errors.
Dr. Hemant Joshi, yeah, thank you. Anybody has any questions?
Ma'am, just one clearance. This collaborator is being used both for the total tonsillectomy and the intracapsular tonsillectomy also? Same thing?
Yes, yes, we use it for both tonsillectomy, intracapsular and extracapsular. However, for extracapsular, it is not very, very different from doing a normal cold and snare method, because any which ways we are going to remove the entire thing. So it's just the dissection part which has to be done. So I normally use it when I'm doing a tonsillotomy. When I'm doing a tonsil surgery for tonsillotomy or reduction tonsillotomy, I use collator more, but it can be used for both. Any other questions? I believe I can't see any more questions on the chat. Do we have anybody from the marketing team? Can we just close the session if nobody has any questions? Dr. Hiren, are you there? Dr. Sonu, shall I log off? Or okay, is there any is there less delayed bleeding with coablator use? Yes, certainly. So we have seen that we have never come across a patient who has bled post-operatively in our cases, because the reason being we are seeing the tissue under vision with the help of endoscopes. The coablator has an inbuilt ability to coagulate. So we make sure that we coagulate every bleeding point. And we make sure that when the child wakes up and everything, we are sure that there's no bleeding. So the chances of delayed bleeding or the reactionary bleeding is also less. Also, I would like to mention that the reactionary or secondary bleeding happens because of the infection. So what is important is that we tell our patient to maintain a very good oral hygiene, because it is the infection which leads to bleeding later on and not the surgery per se.
Thank you, Shruti. I think if there are no questions, you could close the session yourself.
Sure, ma'am. Sure. Thank you so much, everybody, for the patient listening. And I thank all the other speakers of the day. The overall, the webinar was quite informative. Thank you, everyone for attending. Thank you so much. Bye.
Good day.
Bye. Good day.